I will start the presentation in a second. Just need to open it for you. So here it is. Okay, so we are ready. Dr. Andreas, thank you for sticking up with us as well and not running away. And of course, we can, it works now exactly. So we can start with your presentation. Ready?
All right, so let's start again. Sorry for the bumpy start, but I'll just start from scratch. Yeah? As you know, and as the kind introduction of Caroline told you, we'll be talking about the options, the reproductive options in the age segment 40 plus. And talking about advanced maternal age, we will not be getting around to talk about socio-demographic change. Because if you look at the last 40, even 50 years, there has been a constant tendency in postponing childbearing, a constant increase in maternal age and first-time mothers. And as you can see in this slide, it has been a pan-European and even global phenomenon. If you look at the situation today, the probability of giving birth at 40, it's twice as frequent as it was 20 years ago. And that is, as you can see here, that's Eurostat data from 2009. It is a phenomenon that you see all over the European countries. That leaves us with a dilemma, because you could say that, well, no problem with the advances in technology and IVF techniques. You could just balance out the age problem. But it is not as simple. And since a lot of chromosomal disorders are linked to maternal age, there is a problem. And as you can see here, linked to maternal age, there is a rise in aneuploidy, meaning the probability to have a number change in chromosomes, and therefore a problem, a rise in miscarriages. You will be all familiar with Down syndrome, which is the case when there is 3 copies of the 21st chromosome. And the probability, as you can see here, to have an increased risk of aneuploidy starts at 35, exponentially. So a woman in their 40s or even above has a very high likelihood to be affected by a chromosomal disorder. And that is the reason why success rates are low. And the probability, if there is an ongoing pregnancy, to have a affected child is high. Is there awareness about the link between fertility and age, or the reproductive outcomes and advanced age? Well, interestingly enough, if you look at the data and the publications, there seems to be a big misperception of the impact of age on fertility. Be it because it's like a selective awareness. We are all humans, and maybe pay more attention to the information we like to hear, and the information that fits our prefabricated opinion. But since we live in a time where access to information has never been that instant and that easy, it is interesting to note that there is this misperception, or maybe a false belief in that techniques, new advances, can fix the problem. Talking demographics, I wanted to show you this slide that shows you the age demographics for IVF patients in our clinic. And that will be the same, I can tell you, in whatever IVF clinic you look into in Europe. And you can see, if you look at the red slice of the cake, that is the patients who are 40 and older. They make up for almost 50% of our patients. And therefore, this group is very important and worth to look into. Here, I just want you to pay attention to the red circle. This gives you an idea about the started IVF cycles. And the numbers you see here, or the number in specific you see here, is the number of canceled cycles. So you see in the age group of 40 to 42, 32% of the patients who start an IVF cycle, who get stimulated, will not have a transfer. So they start a very complicated, invasive, and also expensive procedure without the benefit of having a transfer and the possibility of having an ongoing pregnancy and a baby. And if you go even further, 43 plus, it's 40%. And that's something that has to be key in the first encounter with the patient. That has to be very well explained in the first visit. Having all these demographic changes in the last years, the scientific community coined an expression, a so-called permanent involuntary childlessness. The risk, basically, to be left without a child, even though every measure was taken to reach a pregnancy. That's data from the United Kingdom, and you see that women born after 1990 have an overall probability to be childless of 22%, and a 15% probability to have their child over or past 35 years. And it's very interesting. That's a second group, also data from the UK. The risk of permanent involuntary childlessness at 30, if you start looking for pregnancy at 30, is 6%, so quite low. At 35, it's already 14%. And if you look at 40 years, if you start to be looking for pregnancy at 40, it's a whopping 35%. So age undoubtedly has a big impact on reproductive outcome. So what do we have to do? Obviously, we have to do a thorough counseling of patients in advanced age. And basis for a good counseling is ovarian reserve testing. So you need to know about the ovarian reserve, the so-called fertility of a patient. And if you go online, you'll be finding a lot of different tests, some commercialized, some genetic tests, very expensive. But here it's important to state that the gold standard remains the measure of the AMH level, which stands for anti-Müller hormone, and the basic ultrasound to look at the antral follicle count, AFC. Both in combination have the best sensitivity and specificity to predict your ovarian reserve and to predict your ovarian response to stimulation. So they are both quantitative markers. So they give you an idea of how many follicles and eggs you might produce under stimulation. Now I'll talk you through the different techniques and how many cycles for each technique are reasonable, when you should switch. So we'll be talking IUI, we'll be talking IVF with your own eggs, we'll look into vitrification and egg donation. If you look at that slide, it's a very interesting study, and the title says it all. The authors of this study looked into the question if you should rather use insemination or IVF in women aged 40 and above. And they call it, the question, or ask the question, do you use the high road or the low road? And the conclusion, in their conclusion, and I highlighted that here, they said, since time to pregnancy in this specific age group is an important factor, if not key, these older patients should be advised that ICSI, IVF ICSI, is advised to be started immediately. So that's an important point. Yeah. Obviously, we'll look into that now. IUI is an option, but there is a big bit of the scientific community based on clinical evidence saying that you should not lose time doing IUIs. 40 plus is an indication to start IVF immediately. We're waiting for the next slide. Let's see. There we are. The same authors, same publication, now look into giving you an answer of, and also the health professionals, how many cycles IUI are reasonable prior to change to IVF. And I want you to look at the blue box here. They split it up by age, and they basically say that there are acceptable success rates until 42. But they say precisely that from 41 years onwards, there is no improvement from the 6th cycle onwards. And from 42 years onwards, there is no improvement from the 3rd cycle onwards. That's important information because, practically speaking, that's an important patient counseling tool. So if a patient insists on trying IUI, she should know that if she's 41, latest with the 6th cycle of IUI, failed cycle, she should switch to IVF. And 42 years, she should not do more than 3 cycles. And that's another publication. And then again, you could ask the question, how old is too old? Are there really good results 40 plus? And here, as I highlighted, one has to say something happens from 43 onwards. You can clearly see that the clinical pregnancy rate, 43 onwards, is very poor. 45 onwards, 0. And that's an important incision. You should remember 43 onwards is another decline in fertility and basically an indication to switch to egg donation. One could ask, well, why should we impose limits on patients? Why shouldn't we, or can't we let them decide? Because I can tell you, in our clinic, like in any other IVF clinic, you will be seeing patients who come to see you the first time at 45, 46, 47 years of age, and they obviously want to use their own genetic material. So why impose limits? Well, here you have the answer, and that is the objective of this talk, to give you some scientific evidence for and also explain our decision-making processes. And here you can see that 45 years onwards, live birth rate is 0. Yeah, and that is why we impose limits. And there are countries where from a certain age onwards, the public health system would not anymore reimburse treatments. And that is exactly for that reason. Yeah, but you should remember that 45 is another incision. Yeah, and so you should limit IVF to patients who are not older than 43, all the while mentioning and stressing out that between 40 and 43, the success rates are not very good. Yeah. Then if you do IVF, how many cycles are reasonable? Yeah, how much is too much? And you can see here, that is the 40-year age group, that between 3 and 4 cycles are basically reasonable. We'll get to that in the next slide. And the authors of this particular study concluded that as IVF may largely overcome infertility in younger women, you see here the age group under 35, it does not reverse age-dependent declines in fertility. Translated, it means that unfortunately in advanced maternal age, even advanced IVF techniques don't do the trick and can't really help you. So concluding, IUI versus IVF, 40 years is an indication to directly start with IVF. IUI shows acceptable delivery rates until 42, but patients should not be encouraged to do more than 4 cycles. Let's go on. I already touched that topic. How many cycles IVF are reasonable? The authors of this study clearly stated that patients reach a plateau. So there's no increase in success rates after 3 attempts. And patients aged 43 should be counseled thoroughly that they do not have a realistic chance of achieving a live birth with their own eggs. So clearly the message here is maximum 3 cycles and switch to egg donation from 43 years. Now, this topic, PGS, pre-gestational screening, nowadays called PGT-A, the genetic testing of the embryos. This is enough. It's another topic. It's enough for another webinar. But I just wanted to scratch this topic, because it's often used as a solution in advanced maternal age, meaning that it's used to top up IVF cycles in a special way in women above 40, saying that this will up the chances and give more a success rate. And that has to be handled with a lot of care. So I just want to tell you the scientific basis and how many eggs and embryos you really need to properly perform embryo biopsy. It's scientifically accepted that PGT-A has to be done, so the analysis of the embryos has to be done at day 5, at blastocyst stage. If you do not reach blastocyst stage, you can't do it. And the criteria to reach day 5 is minimum 15 mature eggs, M2 stands for mature eggs, or 8 or more top quality embryos at day 3. All the studies that indicate the usefulness of this technique have been performed in good prognosis patients with a lot of eggs and under 35. Clearly, that's not the patient clientele we're talking about in advanced maternal age. And it's just a reminder. Again, this topic is so complicated that it would be enough for another talk and webinar. But take-home message here is that a lot of patients 40 plus will not produce 15 or more eggs, will not have 8 or more top embryos, and most likely a lot of them will not reach blastocyst day 5 stage, where it's imperative to do the embryo biopsy if you want to benefit from this technique. Another topic often used or asked by patients 40 years, 41, 42 years, if this would be an option, and I'd give you the answer and then give you the explanation. It is not a good idea. It is not an option 40 years plus. Why? Here, this is an Italian group, Renzi et al., who did very thorough groundwork. And basically, important to know that the studies who showed the efficacy of vitrification were performed in women under 37. And the minimum number of eggs, mature eggs, necessary to have a proper probability of an ongoing pregnancy is 9. A lot of women 40 years or older will not have this number in one session. And the following slide is a very useful patient counseling tool. It's from a recent study, 2017, to basically tell you and us in general how many eggs are necessary to give you a probability of a live birth. So down here you have the mature eggs, the number of eggs. Up here you have the probability of a live birth. I go to the extremes. This line here, the lila violet line, is 44 years of age. If a 44-year-old patient would have 10 eggs, she would have less than 10% probability of a live birth. We go in the high road. This is the light blue is a donor. Average age of a donor in our clinic is 25. If a donor, not a 25-year-old woman, would have 10 eggs, she would have an 80% probability of a live birth. If you use a 40-year-old woman here, if she would have 10 eggs, she would have a 30% probability of live birth. See, this is a very useful tool to visualize the connection between egg quantity and age, the impact of age on egg quantity and on probability of success. And concluding vitrification, it's not an option. It's not an option for patients 40 plus. That brings us to egg donation. Egg donation means that basically a young donor, I'm talking about the situation in Spain now. By law, egg donors have to be between 18 to 35 years of age. As I already mentioned, the average age in our clinic is 25. And the egg donor is stimulated, gives us the eggs under anesthesia. Then the eggs are either injected with partner or donor sperm of the patients. And the embryos are developed in vitro to blastocyst stage and then transferred in the patient's recipient's womb. This technique obviously gives you the highest success rates because it eliminates the age factor. Yeah, because regardless of the recipient's age, success rates are defined by the donor's age. So if you are a recipient 25-year-old with a premature menopause, 35 after 5 failed IVF attempts, 45 years, or 50, 51, which is the age limit in Spain, with a menopause, you have the same success rates. There is no age groups. Indications for egg donation, as I already mentioned, IVF failure, premature ovarian failure, premature menopause, age 43 years onwards, and genetic indications. Success rates are, if you look at the first transfer, almost 60%. Then they go up. Cumulative pregnancy rates after 3 cycles egg donation reach 93%. Obviously, egg donation is difficult to accept. It's a hard pill to swallow for patients. It's legally challenging because there is a lot of countries who do not have egg donation. Like, as you know, I'm from Germany. In Germany, egg donation is not legal. Like in Switzerland, other countries like France have egg donation, but they do not have donors. So there's a lot of limitations in getting access to egg donation. But of all techniques I told you in this age segment, it gives you the best success rates. I'm coming to the end of the presentation, and later on you'll have the chance to ask questions. Concluding, due to the social demographic changes, we have a high impact in reproductive behavior and demography of various countries, as you have seen. There's an important lack of information or a misperception regarding the impact of age on fertility. Results in patients 40 years and plus are acceptable, but overall poor if you work with your own eggs. Health professionals therefore should encourage women to have children sooner. Vitrification for fertility preservation is an option, is effective, and health professionals should counsel about that. But it is not an option for patients over 40. Egg donation is the most effective treatment, but difficult to realize in certain countries. And last but foremost, something we should not forget, because sometimes this is forgotten or neglected by the patients and not touched by the health professionals. Obviously, in advanced maternal age, we face higher obstetrical risks, and that should be part of a thorough counseling in the first visit. It's not to be forgotten. And this way I reach the end. Thanks for your attention. I think I was in the time frame of 25 minutes, and we will be now having a question and answer session, and I'm happy to answer your questions. And obviously, so you know, in case there are remaining questions and you would have or prefer to ask your questions in a more personal setup, you can obviously contact us, the clinic directly, and we are happy to do one-on-one second opinion or telephone visits. There's no problem there. All right.
Perfect.
Thank you very much.
Thank you so much, Dr. Andreas, for that presentation, for explaining all the details, for tackling this important topic and providing us so much information. Definitely useful one. And yes, it is definitely time for our Q&A session. So we do have questions ready. So let me just go to the very first question for you. And here it is. After how many cycles with my own eggs should I go with egg donation? I had 3 cycles, I'm 43, and obviously have indications for egg donation. However, still trying own eggs. When is the moment I should say, okay? And there's a follow-up just to quickly, how egg donation looks like in the UK. I mean, donor availability. I'm Caucasian.
Okay. All right. Well, it's a very good question, because I hope you have access. You will be even later on having access to my slides, because if you remember very early in the presentation, I showed you a study who talked exactly about this answer. Basically gave you the answer to your question. Because if you have 43 and you've already tried the IVF road, and you had 3 failed cycles, it is a clear indication for egg donation. I can even use the words, it's a rock solid indication for egg donation, because you've tried with your own eggs, however the cycles went, I'll not dig into details. If you had transfer, if you had a good response, if you reached day 3 or day 5, the sheer fact that you tried with your own eggs, that you had 3 failed cycles, is an indication, because if you remember the slides, you reach a plateau after 3 cycles in a special way at patients 43 years and older. You should go for egg donation, without any doubt, the moment to change is now. And the follow-up question regarding the donor availability in the UK, well, that's a tricky one because the UK is an example. The legislation in the UK talks about an open donation, so it's not anonymous. This setup usually goes along with problems to find donors, to recruit donors, because it means that the child has the right to know its genetic whereabouts. Usually there are more donors available in countries who have an anonymous donation, like in Spain and other countries. So the egg donor availability, I can tell you, since we also collaborate with clinics in the UK, is poor. Since you're Caucasian, you have higher chances. But if you are of Black ethnicity or Asian ethnicity, it's very, very unlikely, or goes along with long waiting lists. But in general, there are waiting lists in the UK, so the donor availability in general in the UK is poor, and they seek for options abroad.
Perfect. Thank you so much for answering that very first question. And we have more questions coming, so let's go with the next one. Would you recommend immediately in your clinic an egg donation treatment for a woman aged 43, or you still look and consider her case before that?
That's a very good question, because obviously we will always see. We'll always, if I talked about thorough counseling, and the presentation was my attempt to give you an idea about our decision-making process, our algorithms, the clinical evidence we use to reach a conclusion. A conclusion meaning the right technique for every patient. And when I said that 43 is an indication to switch to egg donation, I also said that it's a tough pill to swallow, because nobody wants egg donation. I would gladly offer you a technique with your own eggs that gives you a proper chance, a good shot to have an ongoing pregnancy and a live birth. But one has to be very critical. And if the patient has been counseled properly and she's aware of the limited success rates and the very limited options and the high probability to also have a cycle cancellation, and she still wants to go for it, obviously, we'll consider her case, we'll explain what is possible, and if she's really adamant about to try with her own eggs, she'll be able to do so. If there's no contraindications, meaning we test the ovarian reserve, obviously somebody with a low or undetectable AMH and no antral follicles will not be getting the go-ahead to try. But if there is no contraindications, we will try, but we will not let a patient go for IVF with their own eggs from 46 onwards.
For your recommendation as well as your question. And there's another question right here. So you mentioned for over 40 should not do more than 3 cycles of IVF. Do you mean at the same clinic?
No, that accounts for the total number of cycles, because switching clinics doesn't change your age, doesn't change, that means over 40, you should not do more than, over 43, not more than 3. In general, after 3 to 4 cycles, you reach some sort of plateau. And that accounts for the total number of cycles. So it doesn't mean if you did, I know patients do that sometimes. I can tell you just recently, I had a German patient who came to Spain to see us, and she did an unbelievable number, the number of 13 IVF cycles before coming to us to switch to egg donation. So no, it's 3, the total number of 3 cycles.
for answering that question. We have another one here, so let's go to it. So, does human growth hormone improve the egg quality?
Mhm. That's an excellent question, because it's it's the tip of an iceberg of a lot of treatments and measures with the aim to improve egg quality and or quantity. And here, if you go strictly, let's say, by the book, and try to give an evidence-based answer, one has to say the following. All treatments, and the internet is full of, if you Google, yeah, you'll find treatment with human growth hormone, treatment with DHEA, and a lot of other substances, with the aim to improve egg quantity and quality. And if you look at the evidence, meaning studies with control groups who have shown more outcome, meaning more retrieved eggs, more retrieved embryos, I have to say no. So to cut my long explanation short, the evidence-based answer to this question is no.
Thank you so much again for your question and your help with it as well. And there's another question. So I'm 37, but my AMH is that of 44-year-old, 0.33. How do I approach this? Have some 6 fresh and frozen transfers now.
Okay. Well, first of all, if I don't understand the second part of the question, have some 6 fresh and frozen transfers now. Well,
If you could get back to us, but I believe it's about that the patient already had.
I think so. Yeah, that she had
Yes,
6 fresh and frozen transfer
I believe so.
with her own egg.
Let's wait. Yes, have done. Right.
Okay. All right. So, see, to simplify, age is egg quality. AMH is egg quantity. So measuring AMH and antral follicle counts give us an idea, or are predictive factors to predict how many follicles and eggs a patient will produce under stimulation. So if you balance both, obviously you need quality and quantity. But being younger, you're 37, but unfortunately you have a low ovarian reserve. So you have a low value of the AMH that tells us you'll not produce a lot of eggs. You've been stimulated, you've produced some eggs, and you've done transfers. Well, the question when to switch to egg donation in younger women is a difficult one, because this talk was about advanced maternal age. If you're 40 plus, you do not have egg quality, and you lack both things. You don't have egg quality, which is age, and you usually do not have a good quantity. In women under 40, in women under 38, egg quality is still there. This is age. So the decision-making process when to switch to egg donation is a bit more tricky, and one would be more likely to have a last try with the own eggs, ever since there is quality, which is age. So it all depends on, it's not just the AMH, it depends on your antral follicle counts, how many eggs have been retrieved in the various cycles you've done, how good the embryo development was, because at 37, if you produce various embryos, and if you could transfer 2 embryos at day 3, or even reach day 5 and transfer 1 blastocyst, or maybe 2, you still have a good probability of a live birth. But obviously, in your case, one would have to check also if you already had various transfers, if there's nothing on the endometrium. So that is a case where I would need a little bit more information, and that might be a case where we, in terms of a second opinion, we could dig a little bit deeper into the details to give a more precise and more detail-founded answer. Yeah, but if you no, I hope it's clear. In your case, 37, one would be still a little bit more pro trial with your own eggs before going for ectonation.
Perfect. Thank you so much for your recommendation as well and your detailed answer for sure. And just to let me remind you that if you would like to get in touch with Dr. Andreas and his team, you can go to the website. I just send the link in the chat section. Once you click on that, you will be able to just ask your questions and get some advice, etc., from the team as well as Dr. Andreas. Okay. Thank you. And now let's go to the next question. I'm 38 and I keep trying with my own eggs. I had 5 transfers, 4 egg retrievals when embryo quality is good and my overall healthy is good, but I still don't get pregnant. Should I go ahead with egg donation immediately or should I keep trying until I'm 40?
Well, this question is a bit in line, following up with the previous question. And there again, in your case, having had 5 transfers, 4 egg retrievals, so 4 cycles, it is something, you're under 40, it's something worth the while to examine. And I'm pretty sure that sounds like you've most probably have done the additional exams, looking into the quality of the uterine cavity, meaning hysteroscopy, biopsy, maybe also endometrial receptivity, maybe looking into the factors that are checked in terms of or in cases of repeat miscarriages or failed IVFs. So if you've not done this battery of tests, it would be something to consider. And again, because you're under 40, yeah. If one would always be more motivated to go along with your own eggs, but obviously one has to investigate more thoroughly the other factors. Also know about the fertilization rate. Sometimes it's worthwhile to look into the sperm factors, to do sperm fragmentations, because sperm can account for failed fertilization, but also failed implantation. So I hope that gives you an idea, and that would be also a case where one would need to give a good second opinion, need a little bit more detail. But one could be, just as the patient asking before, a bit more motivated before going for ectonation.
Actually, there is a follow-up question from the very same patient. So, so I never had endometrial receptivity done. Should I do it then?
Well, in patients, generally speaking, in patients who are generally healthy, both partners, who have done various cycles with a good response, fertilization, creation of embryos that have implanted or not, it's a standard examination to look into the endometrium, so to do a hysteroscopy, to do a biopsy, and on top of that, one could also look into, at the same time, the endometrial receptivity, because yes, you might find answers to the question why it didn't happen so far. You might find an underlying problem. So that would be one way to look into, one factor to look into. Yes.
And this is like a comment from the very, very first, very previous, sorry, answer actually you provided. So just wanted you to see it. Uh,
Yeah.
you just got diagnosed with endometriosis. You're very good. Just wanted you to see it. This is like I've mentioned from the very first, very previous question. Okay. All right. Thanks so much. And now we will go to the next question. I am Afro-Caribbean with one fate cycle, my own eggs, 42, looking to go with double donation. My own eggs are not viable and happy with that. What availability is there for Afro-Caribbean or darker donors? I am looking at Spain in such case.
That's a very good question. That's a very good question, and a very interesting question also for no, the greater audience. So I will tell you a little bit about our donors in Spain in general, and then in our clinic. I can tell you that the donation is anonymous. Yeah, so by law, donation has to be anonymous. In our clinic, I can tell you, we are based in Barcelona. 85% of the donors are Spanish, no, from Spain. 15% are not Spanish. All of them are residents in Barcelona. That gives you an idea about the background of the donors. And coming back precisely to your question, yes, we do have, as you put it, darker donors. Yes, you have to know that there's more in general in Spain, and Barcelona is the second biggest city in Spain, very cosmopolitan. But we have more immigration from Latin America than from Africa. We have both, but there's much more immigration from Latin America than from Africa. And as I told you, we have the whole spectrum of ethnicities. Yeah? And since roughly 90% of our patients come from abroad, from France, England, UK, Germany, whole of Europe, and overseas as well, you can imagine that we have all kinds of ethnicity on the patient side. So yes, we do have African or Black ethnicity donors. There are waiting lists, which usually not tend to exceed 3 months. Since we have, and that might be an important information for you as well, if we do not face crisis like this, which is unprecedented, we have two sources of eggs. We have a big egg bank, actually one of the biggest egg donation programs in Europe. So we have frozen eggs, vitrified eggs, and if we have usual conditions, we have always donors under stimulation. So we have a source of frozen eggs and a constant supply of fresh eggs. And it could as well be that we happen to have the perfect donor of Black ethnicity, but usually a patient with your background has to be advised and prepared that there might be a little wait for a donor, but you can be sure we have a lot of patients from France and the UK with the colonial past. There's a lot of Black ethnicity, also Asian ethnicity, some mixed race couples, single women. So yes, we have donors for you.
Perfect. Thank you so much again for explaining this to us and sharing the information as well. There's a follow-up question from the very same patient right here. Maybe you have some comments. So I am diagnosed with endometriosis, fibroids, and had left tube removed. My environment was inhospitable.
Okay, so that is a mix. So first, endometriosis per se is not, if you talk egg donation, endometriosis is something that affects the organs outside your uterus. Yeah, and affects very much the ovaries, and it's known to reduce the ovarian reserve. So outcome using your own eggs, stimulation, IVF, will be poorer having endometriosis. It does not affect success rates in egg donation, because for egg donation we just need the inside of your cavity. That's one thing. Fibroids is a different topic. Obviously, we do not, I'll come to that. If your tubes are removed, no problem whatsoever, no impact on the receptivity of your cavity. Fibroids are a different topic. There, we would have to look into what kind of fibroids you have. There are 3 types of fibroids. The one outside the uterus, the so-called subserous fibroids, they don't bother us, and unless they're very big, but we don't touch those fibroids usually. The ones who are in the wall, intramural, they do not bother us usually if they are asymptomatic and not exceed 5 to 6 centimeters. And most of all, do not imprint or impact the cavity. The ones who cause problems and should be removed are the submucous fibroids. So in your case, one should know, and that you know by doing an ultrasound prior to treatment, what kind of fibroids you have, and if you need treatment before going ahead with an egg donation and a transfer. Yeah, that's basically the answer. So no problem for the endometriosis, no problem for the removed tube. For the fibroids, one should know more about the localization of the fibroids.
Providing that advice as well. And we do have another question coming up here, so let me go to it. Would you recommend PGS when using donor eggs, as it is expensive?
That is an excellent question. That's a really excellent question. And as I told you before, PGS or PGTA, as it's called nowadays, is a vast topic and gives us enough material for another webinar, another talk. But it's a very good question, because yes, it is very expensive. And as I try to tell you with this one slide, where I told you I just scratched the surface of this topic, it is not recommendable in egg donation. Yeah, it makes literally not a lot of sense. Why? See, egg donation means we use young donors. That's a highly selected group. To have an idea, our donors undergo 10 to 15 visits before they become donors. So they're tested and selected. Just 30% of our donors reach donation. So 70% of the young women who present themselves in our clinic will not donate their eggs for various reasons. So it's a highly selected collective of donors, young, healthy, without any problems in infertility, and without any indications in their past medical history and their family history of severe genetic problems. We do carrier screening for recessive diseases. So, long story short, it's no indication to do PGS in young, healthy women. And since it is very expensive, one has to really ask the question why one would or a clinic would recommend PGS in egg donation. I don't see any indication really. And unless the male partner, the male partner would have a specific genetic disease that needs biopsy, but that is very, very rare. Yeah. So in general, PGS is not indicated. I don't see any indication for that in egg donation. No.
The question as well as the answer. Next question is, what do you think about PRP, ovarian rejuvenation, when 40 plus age is concerned?
Well, PRG, I don't know the abbreviation.
PRP.
PRG. So if that stands for ovarian rejuvenation, I come back to something what I said previously. There was a question regarding growth hormone. I talked about DHEA. See, there is a lot out there with the intention to rejuvenate ovarian tissue cells. A good friend of mine is a professor at Stanford working with stem cells. They are working hard on this topic, and they succeeded in mice. So in the future, but unfortunately not in the near future, we might have this option, meaning that we can reprogram stem cells, create omnipotent stem cells, and then tell them to develop into eggs, ovarian tissue, sperm cells. We are far away from that. It works in mice. It doesn't work in humans. And anything on the market, yeah, that promotes success can't really be trusted. Yeah, I strongly disencourage you to do these things. The only thing where there is a slight evidence with regard to increase the number of eggs, so the egg quantity, not the quality, is DHEA. That's a supplement it's a precursor. It's not a medication in Germany. It's not it's a supplement. It's not even regarded a medication. And there are publications that might increase the number of eggs, but it's controversial. So I have 50%, 50% of the publications say yes, 50% no. There's nothing who has scientific evidence to rejuvenate eggs or ovarian tissue. So I hope my answer is sufficient to your question. Unfortunately, I'd love to have something. Again, I would love to give you something, but we have to, be evidence-based, and no, there's nothing like that.
Perfect. Thank you so much for clearing this up for us as well. And let's go to the next question. So, are you offering counseling during the quarantine? Should we wait until everything goes back to normal?
Oh, no, we do offer counseling. Yeah, we have a lot of our doctors in home office, and we do that. And you're all very welcome to contact us. And because obviously, see, we're all in lockdown. The whole of Europe, the whole world is in lockdown. You're at home. You might as well use the time to have a second opinion, or to have counseling, to do your homework, to update your medical file. So I would advise you to contact us or other clinics to have counseling. Yes, yeah, and you see, this is a very potent tool, the webinar, but on a one-to-one basis, we obviously can dig much deeper into your case and go to the ground of the problem. And that is something I would strongly encourage you to do. Yes.
Perfect. Thank you so much for answering that question. And of course, your advice definitely remember that if you wish to get in touch with Dr. Andreas and his team, you can also use the link that I have just sent, and you will be able to provide all the details and just schedule even a consultation, I am sure. So if you would like that, go ahead and do it, of course. And let me go to the next question. On cycles with egg donors, always do you do ICSI or conventional IVF?
Mhm. That's a very good question. Actually, this question and answer is a potpourri of the questions, the frequently asked questions in our first visits. Yeah? And yes, so we do see we are a very big center by now. We do around close to 10,000 cycles every year in Barcelona, and we usually do ICSI. Yeah, on demand. Sometimes, once in a blue moon, we have patients who want to do conventional IVF, and we can do that, but on a regular basis, we do ICSI.
For confirming that and answering the question. Now we have another question here. So it is, I am 44-year-old. I have just started to consider egg donation, but I'm worried the current pandemic has meant everything is now delayed. How successful is egg donation at 45?
Mhm. Well, that's an easy question, and I can give you a lot of reassurance. Don't worry. Well, as I told you, in the part where I talked about egg donation, but maybe that didn't come out clear, and there's a lot of information. See, egg donation, there's no age groups. Your age as a recipient has no impact on the success rates of egg donation. So if you are an egg donation recipient patient, and you are 25-year-old and you have a premature menopause, we have these patients. It's rare, fortunately, but we have them. So if you are 25 and receive egg donation, you have not higher chances than you being 44 years old. See, the age limit in Spain is you could do egg donation until 51, actually. We would have to transfer the first embryo before your 51st birthday. By law, that's the limit. And a patient at 50 doesn't have lower chances with egg donation than you. So don't worry. Yeah, there's no impact on your success rates. Obviously, this pandemic impacts a lot of our patients, and everybody is impatient and wants to start as soon as possible. But don't you worry. This delay, this wait, will not down your success rates. Not at all.
Again for that advice and for reassurance as well. Thank you. And let's go to the next question. I am considering embryo adoption as one of our options. My partner is Asian, I'm Caucasian. When I asked a few clinics in Spain, they said they had some half Asian embryos, but since the donation is anonymous, I will not know which country the donor came from. Asian is very broad term. Vietnamese is so different physically and ethically from Indian or Japanese or Chinese. Is this really not allowed for clinics to let us know?
That's a very specific but a very good question, because that let me dig deeper into the selection process, and I can give you an answer. Don't worry. See, I'm totally with you. See, it's 13 years that I've been working here. I've seen the development of the clinic, and since 90%, as I told you, of our patients come from abroad, we have a wide spectrum, very cosmopolitan patient clientele with all different ethnicities and phenotypes. And you're totally right that Asian is a very broad term. And when I said Asian ethnicity, I'm totally aware that that is not the right, it's too global term, because Chinese has nothing to do with Japanese, has nothing to do with Vietnamese or Malaysian. There are big differences in phenotypes and expressions. Unfortunately, if there is an anonymous law, it goes along with the fact that you cannot disclose more than age and blood group of the donor. I'm talking Spain now, yeah. And obviously, as I answered in the previous question, see, the situation in Barcelona, in our clinic, is, as I told you, 85% of the donors are Spanish, 15% are not of Spanish descent. We have Asian donors, but not a lot. We have mixed race donors. And so if this clinic told you that they have some frozen embryos which would match, but they're not allowed to tell you the origin, it is true. But I can tell you also, to be transparent, now I'm talking about us, we as a clinic will always try to be as transparent as possible. And if there is a wait, and usually for these rarer phenotypes, there is a waiting list, but we'll always try to be as transparent as the law allows us. And we'd always tell you, well, we do not have the ideal donor for you. We have a mixed race donor, and so on. In the special topic of embryo donation is a very specific one, because there the selection is even more limited. There's an even bigger bottleneck. Why? Because the origin of embryos who are donated for the time being is of double donation. So that's embryos who derive from egg donor plus sperm donor. Then if a couple or a single woman who used double donation has remaining embryos, usually we try to reach day 5. So then let's say she has transfer unsuccessful, she will use her frozen embryos and use up this reserve. If she had a baby, she might use these frozen embryos for siblings. This all tells you that we do not have a high quantity of frozen embryos for embryo donation. We have them, but it's a very select number. And then there's not a lot of choice there. But coming back to your question, it's true. Yeah, we are not allowed by law to disclose the nationality. So it will always be as close as possible to your phenotype. That's true. Yeah, and if we do not dispose of a donor or embryos who fit that criteria, we'll tell you. But we are allowed to tell you age and blood group. And then later on, if you are pregnant and have an ongoing pregnancy and you're close to delivery or the baby is born, you can have some more details regarding the donor. But it's not, the nationality is not part of that. That would be the answer to your question.
Clarifying that, very important question for sure. Many patients are wondering how exactly it works. Thank you so much. And now let me go to the next question. So there are a number of clinics that offer mild IVF. What are your thoughts on this? They claim that it aims to produce less eggs but higher quality.
It's an excellent question. A very, very good question. And well, that would be a nice topic for another presentation. Yeah, this could fill easily an hour or two. Let me give you a brief summary. Actually, in our group, we have a clinic, that's the Copenhagen Fertility Center, whose expertise, Professor Lindenberg, he's the head of a department and founder of the clinic. He's a world expert on mild stimulation and mild IVF. And well, the dictus is, yes, so basically the train of thought is, well, mild IVF is more physiological and produces less eggs. It's less invasive, less hyperstimulation, and the eggs are of better quality. Well, if you look at the data, you can fill hours of controversy. It's to an extent that you have believers. It's to the extent that you can. There are strong believers and strong disbelievers. I would say you have to be in the middle. I do not think that you can generally say that less stimulation produces always higher quality. In a special way, if this might be a solution for advanced age, you have to be careful, saying that in advanced age mothers, mild stimulation produce better eggs. Be careful. But it could be an option exactly for that group, because I'm going to tell you now. See, I was telling you before that advanced age mothers, 40 plus, usually have, well, by age, they have low quality. Egg quality is a problem. Age is egg quality, so they lack egg quality. On top of that, most of them have a low ovarian reserve, so they lack egg quantity, which results in the fact that they usually do not respond well to high hyperstimulation. And especially in that age segment, it is actually a good idea if a patient, let's say between 40 and 43, is adamant and wants to try with their own eggs, but has a low ovarian reserve. It is a fair approach to say, well, if I know that she will not respond to a conventional IVF, hyperstimulation, I can do a mild stimulation approach, knowing that she'll give me less eggs. I'll not go into the topic of the quality because it's so controversial that you'll find data to back either way. The ones who say that's nonsense, and the ones who are strong believers and will tell you less quality, less eggs, lower stimulation, less eggs is better quality always. I'm not going there, but it can be a good approach for the patients who want to try with their own eggs, have a lower AMH, have not well responded to a conventional cycle, but are not ready yet to go for egg donation. But you cannot generally say that this is always a good approach. But yeah, it's a good idea. And again, we have one of the world experts on mild IVF in our group. I actually, since a lot of German patients go up to Copenhagen, I'm frequently there every 2 months, roughly. I'm up in Copenhagen, and we work together. And it's a very fruitful and delightful collaboration. And if somebody thinks about mild IVF, that for sure is a good address, because they have a vast experience with this topic. Yeah, and it's in Copenhagen, and Copenhagen is a very nice city, by the way. I hope that answered your question.
Perfect. Thank you so much for your detailed answer. And there are like 3 questions left, so we will be slowly finishing. However, if you have any questions left, go ahead and type them now so that Dr. Andreas can help you out a bit. Okay, and now there's the question here. What are your thoughts on flare protocols for patients with lower ovarian reserve?
That's a good question as well. See, in patients with lower ovarian reserve, you have to be more creative. Yeah, totally pro flare protocols, but again, these patients usually, if I'm imagining now a patient who has a lower ovarian reserve, maybe already some failed attempts, low response, failed response, cycle cancellation. These are patients where the doctor really before he can give a proper second opinion, has to dig deep into the previous cycles. Deep means detailed in what type of protocol, dosage, how many days of stimulation, how many follicles retrieved, how many eggs mature. And when I say you have to be creative, well, that can be a flare protocol, flare-up protocol. That can be a treatment with estrogens in the cycle prior to start the IVF cycle. That can be double triggering. So there's a lot of things in the toolbox where there is clinical evidence to use, yeah, and it can be an option to use in ovarian reserve. But maybe this patient, that would be a case where it's really worth the while to have much more detailed information, to not be vague. But yes, flare protocols can be an option for low ovarian response patients, to try, always with the intention not to pass on to egg donation, to kind of have something, the last reserve, before changing the technique.
Again. And as I mentioned, there are like 2 or 3 questions left. I see that someone has added one more, but let's go to the next one. Can a type 2 submucosal fibroids measuring 17 millimeters and 6 millimeters need to be removed before IVF?
See, in general, submucosal fibroids are an indication for removal. 6 millimeter is very small. Yeah, 17 millimeter is a fibroid which is bigger, and because 6 millimeters, that's even hard to find. You have to think about the surgeon. 6 millimeters is really hard to find. You'll see it with the ultrasound, but you might not even see it. You might not get a visual when you are on it. But 17 millimeters, in a special way, if it's a case of already repeat cycle, failed IVF, it's a strong indication to do it. Yeah.
Thank you so much again.
Yeah.
Let me go to the next question. What of post-thyroidism? And I am single Portuguese lady. I had 3 miscarriages, natural pregnancy, 1 miscarriage with insemination, and 3 failed IVFs. And I am 49. I want to have embryo donation. Would you then accept me as a patient?
Yeah, that's a very easy answer. Yes, I'll tell you why. First of all, because there's some. I imagine you want some response also to the first part of your question. Yes, we accept you until 51. Yeah, we would accept you. Yeah, so that means we would have not to do the transfer before you are 51. One. Second, as you might have learned from the previous question regarding embryo donation, sorry, I told the previous patient that we do not have a lot of embryo donation. So there is always a wait. Yeah? But yes, we would accept you. And your Hashimoto is no problem. We have a lot of patients with Hashimoto. Obviously, we need to check prior that your TSH level is properly leveled. It should be under 2.5. And then that's it. There's no problem. Yeah? But 49, now I don't know if you're 49 plus 1 month or 49 plus 11 months. There's a clock ticking, yeah, and be aware it's your 51st birthday, everything ends. And that means we would have to start the process a bit before. Yeah, we can't do an egg donation in one week. In a special way, since there is a wait for embryos for donation. Yeah, but that should answer your question.
Thank you so much for your question. And now let me have. It looks like this will be our final question for today. So let's have a look at it. What are the success rates for egg donation? I went through 3 IVF with own eggs, 1 abortion, now 44.
Okay, that's an easy question. And for your information, you will find everything on our website as well. Not the success rates are all published, but I'll explain because sometimes the slides are a bit tricky. So again, your age doesn't matter. Yeah, with regards to the success rate, it is of no interest how old you are. If you're 44, 50, or 25. You had 3 failed IVF cycles. It's a classical indication for egg donation. So you're a classical standard patient. And with the first transfer, you would have roughly 60%, so 59%. So a success rate. That's clinical pregnancy. Yeah, 60%. Then you will find on our website, and that's what I told you in the presentation, that there's a cumulative pregnancy rate. So it goes up. And why is that? I'll just skip back into nature to make you understand why the success rate in egg donation will go up. See, egg donation has the success rates thanks to egg donors. The average age, I told you, for the egg donor is 25. Let's imagine a 25-year-old woman in nature having a normal partner, various intercourses around ovulation. This lady, this woman, and I'm talking about the woman because the eggs are more important than the sperm, with various intercourses per ovulation would have 20% success rate in nature. We'd all agree that's not a lot, but nature gave us a very, not a very efficient reproductive system. But if this woman would try every month, after 1 year, after 12 months, she would reach 90% success rate. But why is that? 12 months means 12 ovulation. That means 12 eggs. And if we then imagine, which is not always the case, but let's imagine it always comes to fertilization, that would mean 12 embryos. So in nature, you need 12 eggs and embryos to up your chances from 20% to 90%. And that is reflected in the success rates of egg donation. And that's why you see that after 3 cycles of egg donation, we have 93% success rate. So I can tell you, obviously, there's not 100%, but very close. So I can tell you egg donation will work. Unfortunately, I cannot tell you when, with which transfer. But I'm very confident to tell you that it will work eventually. Obviously, I want to see my patients twice, in the first visit, and then at the first transfer, and then never again. That would mean we have 100% success rate. But sometimes, and that's why I try always to be transparent, we need to do more transfer. But again, to cut my explanation short, with the first transfer, if your uterine cavity is normal, at your age, you have roughly 60%. And then it goes up consecutively. That's the answer to your question.
Excellent. Thank you so much for detailed answer, and I believe that was our last question for tonight. I don't see any more questions. However, remember that if you would like to ask any other questions, remember you can just simply get in touch with the Dr. Andreas and his team with this link right here. And well, I would like to see it show you that there are some patients that are really they appreciate that you have been able to answer the questions. You can have a look at this. This is thanks so much for such a detailed answer. Really kind. I will check my notes from the consult regarding fibroids. Great info on donor origin. You are very clever people. So this is thank you so much for that comment. Thank you so much for joining us as well. And well, there are more of such thank yous. So I just want you to see. Thank you so much for your time. I found this session really helpful. And there's actually another question which I didn't see, but I guess you can answer that straight away as well.
Oh, yeah. Yes, of course. See, as Caroline said, please contact us online and just indicate that you took part in this webinar, and then somebody will get back to you. And based on your availability, we'll have a telephone conversation, and we can have a second opinion consultation without no problem. Yeah.
Perfect. Of course. Thank you so much. And well, we will finish for today. Dr. Andreas, once again, huge thank you for joining our Stronger Together initiative. It has been a pleasure to have you here. And even though we had some technical issues, we have managed. It all worked. And I believe it was very, very useful for our patients. And well, I hope we will be able to do it once again. And well, and one more thing, I would like to thank you all just once again. And let me just remind you that, of course, this has been recorded, so you will still have a chance to rewatch it on our website. It will be available with the same link that I have just sent to you. And you can also find it on our website, myivfanswers.com. Remember, this is a huge source of knowledge. Actually, there are over almost 2,000 questions, with lots of webinars, with lots of online patient meetings already, but also from our very previous sessions. So all of this is available on our site. So go ahead and check it out. And also you will be able to register for our upcoming event with this website as well. Once again, Dr. Andreas, thank you so much. Is there anything you would like to add?
Well, thanks again. I'm quite happy that regardless of the bumpy start, because was fearing that we have to postpone the whole
Yes.
thing, but I think it was very nice. Very nice, very good questions, very good feedback from the audience, and very interesting questions. Yeah, no standard questions. So yeah, I mean, it was a very fruitful and interesting meeting, I'd say. And again, whoever needs a bit, a second opinion or more thorough look at his case is truly welcome. Okay.
Perfect.
So stay safe, everybody. And I hope this nightmare ends soon. And you're
Yes.
obviously very welcome to come to visit us in Barcelona. All right.
Perfect. Yes, fingers crossed it will be over soon. And well, stay safe and well, take care and have a lovely night as well. Hope to see you tomorrow as well. We will be here at 6 p.m. UK time and then at 8 p.m. UK time. So stay tuned. And well, again, have a good night as well. Thank you so much. Bye.
Bye-bye. Take care.